Hello and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Sharif Mursalin. Today's episode features Dr. Zev Wainberg from UCLA, Dr. Funda Meric-Bernstam from MD Anderson Cancer Center, Dr. Alexandra Leary from Gustav Roussy, and Dr. Catherine Fahey from Massachusetts General Hospital. They will be discussing HER2-positive disease in genitourinary, gastrointestinal, and gynecologic malignancies. This episode is a part of a larger educational program titled Emerging HER2-Targeted ADCs in Genitourinary, Gastrointestinal, and Gynecologic Malignancies. For more information on our presenters, along with the link to the full educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
Welcome to this podcast, From Concept to Clinical Reality, the landscape of emerging HER2-targeted antibody-drug conjugates in genitourinary, gastrointestinal, and gynecological malignancies. My name is Dr. Zev Wainberg. I'm gastrointestinal medical oncologist at UCLA, and I'm joined here today by specialists in their respective field.
I'm Funda Meric-Bernstam from MD Anderson Cancer Center. I run the Phase 1 program, which is the Department of Investigative Cancer Therapeutics.
I'm Alexandra Leary, and I'm a medical oncologist specializing in gynae tumors, so ovarian, cervical, and uterine cancer. And I'm based at Gustav Roussy in Paris, France.
Dr. Fahey?
I am a GU medical oncologist, so seeing prostate, kidney, and most relevant to this talk, seeing bladder cancer patients. And I'm at the University of North Carolina in Chapel Hill.
Welcome. And so just to kick us off, we're all obviously familiar with antibody drug conjugates and HER2, but we'll just talk high level at HER2. So, we've known about HER2 for the better part of almost 30 years, beginning in breast cancer and then in gastric cancer secondarily. And, now we learn more and more about it insofar as prognosis, predictive value. Think about HER2 a lot because I'm here at UCLA where some of the early work in breast cancer was developed. So I trained here, and so I've heard about it since I was small. The one thing I remember is that in the beginning, it was very poor prognostic sign, and it was a very poor prognostic biomarker. And on some level, that seems to have changed because of effective anti-HER2 therapy.
For advanced solid tumors, in our practice, we routinely offer next-generation sequencing and offer also immunohistochemistry for HER2. The rationale, of course, is that NGS can allow us to identify HER2 and other alterations, and also, of course, can identify HER2 amplifications and mutations related to HER2. But HER2 amplification in NGS alone is not sufficient to identify all patients that may benefit from HER2-targeted therapy. So HER2 immunohistochemistry allows us to expand the patients that may benefit. Overall, the frequency of HER2 positivity or HER2 overexpression depends on tumor type. So there is a little bit of a variability by practitioner, but in all-comer setting, the positivity rate is around 2 to 3% for 3+. But there are tumor types that seem to benefit from HER2-targeted therapy at lower expression, and we want to be able to identify patients that may also benefit in that setting.
I'll start with gastric cancer. In gastric cancer, we think it represents somewhere around 15 to 18% of the disease. It's different than breast cancer insofar as it's a lot more heterogeneous, and there's a lot more heterogeneity in GI cancers. In GI cancers, there's a lot of heterogeneity in and of itself, but even within gastric cancer, there is heterogeneity in the distribution of HER2 and in the frequency rates. But we think it's about 15 to 18%. I'm curious, Dr. Leary, if you could comment on that in your cancers of interest.
We have known of HER2 amplifications in endometrial cancer for now quite some time, and it represents probably about 30% specifically enriched in certain histologies such as high-grade serous, potentially p53 mutated endometrial cancer. Again, here we're talking amplification. The data gets a lot hazier as you start to say HER2 overexpression, where here it's been less well described in great detail in endometrial cancer. So how many are 3+, 2+, even 1+, because some of these ADCs are going lower. There, the prevalence is still something we're really learning about. In terms of other gynae malignancies, it is much more rare in ovarian cancer, especially in common ovarian cancers. It's a little more frequent in uncommon ovarian cancers such as clear cell, and also relatively rare in cervix. So for now, the leading target for HER2 ADCs is endometrial cancer, but it's also being explored in ovarian cancer.
And Dr. Fahey?
Yeah, I think when we're talking about urothelial carcinoma, we're seeing things pretty similar to the gastric level, things in that 15 to 20%. But I agree with Dr. Leary's point that when we're defining what it actually means, this definition between HER2 1 plus, 2 plus, 3 plus gets a lot more tricky. I was reading an article recently where looking at the HER2 low population, they said in their particular urothelial subset, HER2 low was as high as 34%. That HER2 1 plus, I should be specific when I'm talking about. But in general, when we're talking about urothelial, we're talking about the, 2 plus IHC, FISH positive, or 3 plus. And everything that I found has been kind of the 15 to 20% range.
Yeah, and is there any frequency in any other GU malignancies of interest?
I'm not aware of the rates for the other GU malignancies. It's not something that I've seen commonly come up in my other patients when I send genetic testing. So I don't have the data there to make any strong comments.
Right. So in GI, we do have expression by immunohistochemistry and usually associated with amplification and a few other GI cancers. So we have probably 5% of colon cancer, which is almost exclusively on the amplification level. And in that disease, it's usually a subset, which is left-sided, KRAS wild type, where it seems to predominate. And we actually have drugs approved now for HER2 positive colorectal cancer, which we'll talk about a little later. And in biliary tract cancers, it also represents perhaps up to 10%. There, it's often in gallbladders or extrahepatic cancers. So there is this recurring theme, at least in GI cancers, where it's not uniform, but it is reflected in different heterogeneity. What's confusing is, I agree, this HER2 low question and what that really means that now seems to predominate the discussion in breast cancer, at least in gastric cancer. We haven't yet seen, while there is the suggestion that this group represents a subset, we haven't seen a lot of hard data yet. It's still emerging. Whereas in breast cancer now, it seems the very large percentage of patients have some HER2 staining, which is, of course, only relevant in these antibody-drug conjugates. Dr. Leary, do you test all of your patients for HER2?
So not all of my patients. In endometrial cancer, it's getting increasingly common that people do test, but as you just described in GI cancer, in gynae cancers, HER2 overexpression or amplification is clearly enriched in certain histological subsets. And so most people would agree that in endometrial cancer, that it's useful to test for HER2 in high-grade serous or high-grade endometrioid or P53 mutated, the most aggressive subtypes, actually. In ovarian cancer, as I said, in the common ovarian cancers, we rarely see them. So outside of a clinical trial, it would not be done routinely. One exception, HER2 tends to be overexpressed in rare ovarian cancers. So as I said, clear cell, but also mucinous ovarian cancers. And especially mucinous, people do routinely test for HER2 because up to 30% of that specific histological subtype has 3+ or amplification. For cervix, we don't routinely test for HER2.
So you're doing focus testing basically, and your high grade serous, you're saying, yes, let's test for HER2, and you're doing it on the amplification level.
Yes, and again, this is out in routine practice. It's very different once we're starting to think about clinical trials, and as opposed to the U.S., our approvals in Europe are not quite where you are. So we don't have an approval across HER2 3+. But we can sometimes get it on an exceptional basis if we negotiate well with our hospital. So that would be the cases where we would look for it routine, and that's where we look in specific histological subtypes.
This is an area that I think also is evolving. There's quite a bit of variability from institution to institution about how HER2 testing is done and how HER2 scoring is implemented. For example, in the Destiny Pan Tumor 2 study, patients that had HER2 testing centrally in a quarter of the patients. And that was done using gastric cancer scoring. And the guidance for local testing also was to use gastric cancer scoring. But there are many institutions that actually use breast cancer scoring across tumor types. So definitely we need a little bit more information about how to best harmonize scoring system, antibodies used, and reporting structure.
Okay, and Dr. Fahey, how are you approaching which patients to test for bladder cancer?
If I can correct something I said earlier, we do see HER2 alterations in prostate cancer, but we're not routinely targeting them. To answer your current question regarding bladder cancer, we are sending HER2 testing at diagnosis of locally advanced or metastatic urothelial. And that is because we're sending genetic testing at that point anyway to look for FGFR3 alterations, which we do have additional medications for. So we're sending the genetic testing and getting that information. So we send the HER2 IHC at that point as well, because it's very useful to know for our second line therapies. There are also a lot of trials that are opening up in the frontline setting or in the muscle invasive bladder cancer setting. So I anticipate we're going to be looking at this earlier for the majority of our patients. But for now, I'm sending it when I'm seeing patients in that kind of first clinic visit for metastatic urothelial carcinoma.
I think in general, we should test when we think we will act on the result. Currently, there are certain diseases where early testing is logical. In the early stage breast cancer, for example, HER2 status will affect our treatment decisions. While for other diseases, HER2 targeted therapies are really only approved in the advanced setting that's been previously treated. I do think in the advanced cancer setting, it makes sense to initiate both NGS and HER2 testing early, so that even if there's clearly active other first-line therapy, that at least we'll know what the patient will be able to benefit from next line.
I think we're doing the same in gastric cancer, for example. It's routine. It's been standard of care for about a decade. So we send every advanced patient. So there's a big debate about, should you start sending early stage gastric cancer? We're not quite there yet, but we do send every advanced patient for HER2 immunohistochemistry, which comes back as pretty much the first biomarker of interest. And then we also selectively, I would agree with the comments that both of you made, selectively send for HER2 colon cancer, and at least in our practice, colon cancer and biliary tract cancer, where it almost always is linked to genomic expression. And in that case, we often just send NGS to get it all captured together. So I really think, it's interesting, right? Because you have to kind of know what you're looking for. And we see subtle differences between our cancers about when the right time to send and how to send. But across the board now, we are sending it in a large percentage, I would say, of advanced cancers. And even, we know in lung cancer, there's some frequency there, and our lung cancer colleagues are doing it. So it seems to be the most common biomarker people check for.
Thank you very much for listening to our podcast today. I hope that you were able to learn and gain some insights into the landscape of emerging HER2-targeted ADCs in genitourinary, gastrointestinal, and gynecological malignancies.
Thank you, Dr. Wainberg, Meric, Leary, and Fahey, for a great discussion and for sharing your expertise with us. And many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Emerging HER2-targeted ADCs and genitourinary, gastrointestinal, and gynecologic malignancies, please click the link in the show notes. Be sure to check back soon for 2 more episodes from this program on Episode 2, Taking a New Path, Evaluating Current and Emerging Clinical Data with HER2-targeted ADCs in genitourinary, gastrointestinal, and gynecologic malignancies, and Episode 3, Uncovering Safety and Signposts to the Future, Assessing Safety Profiles of HER2-targeted ADCs and Future Applications.